Bones are essential for movement, posture, and the protection of vital organs. It's a strong yet lightweight material. There are three layers. The outermost layer of the bone is called the periosteum, which is where the blood vessels and nerves reside to ensure metabolic activity at the bone is maintained. The next layer is the compact bone. This layer is hard and thick, and its job is simply to protect the layers below. The final layer is the cancellous bone, which is where the spongy bone tissue resides. It contains a lot of bone marrow within the spaces, which provides the bone's other less frequently known function to produce red blood cells. There are two main cells other than bone cells that take part in fracture healing. They are osteoblasts and osteoclasts. Osteoblasts help to lay down new bone tissue, and osteoclasts help to remove old bone tissue. For information about the different types of fractures, click on the link below. The first stage is the inflammatory stage. This occurs immediately when the injury has occurred and lasts for about 3 to 5 days. When a fracture occurs, the blood vessels around the site of injury become damaged. This begins to form a hematoma, a bubble of blood or bleeding within the tissues. The bone tissue at the ends of the fracture fragments are slowly removed by osteoclasts. A couple of hours post-fracture, the blood starts to form a mesh of clotted blood. Within the mesh is where granulation tissue is laid down to help form a bridge between the two fragments. It's unlikely that a physiotherapist would be required at this point, unless you're a sports physio, in which case you'd be the first to rush onto the scene. Generally, physios would aim to reduce inflammation and pain. Orthopedic doctors at this point may help to realign the fracture to help maximise blood flow and reduce pain. The next stage is callus formation. This begins around the 4th day post-fracture and lasts for about 3 weeks. Here is where the granulation tissue produces cartilage, which is the spongy material in the bone. The osteoblasts help to lay down new bone tissue, and the osteoclasts continue to remove old bone tissue. At this stage, the fracture is quite sensitive, which is why the injured site may be immobilized by either being placed into a sling or a cast. Any movement can cause the two fracture fragments to misalign, delaying its union. It's also why most fracture clinic appointments are 6 weeks post-discharge from the hospital. A physiotherapist would not be able to do much at this stage, other than to ensure that the patient is still moving their limbs distal to the injured site. For example, I fractured my clavicle, and as a result I've been asked to wear a sling to support my shoulder. Now, just because my arm's placed in a sling, it doesn't mean that I shouldn't have to move my hand. Unless specifically restricted by a professional, it's best to keep these joints and muscles moving to prevent muscle wastage. After a couple of weeks, the osteoblasts start to lay down what is called woven bone. This is the first bony contact between the two fracture fragments. The penultimate stage is consolidation. This lasts from about 4 to 6 weeks post-injury. This stage is where the woven bone starts to be replaced by a stronger material called lamellar bone. It's at this stage that physiotherapists start to see patients because a union's formed between the two fracture fragments. The orthopedic consultant would review the x-ray and suggest that the patient be full weight bearing, toe touch weight bearing or partially weight bearing, and that's how we would tailor our interventions. The reason gentle weight bearing exercises are performed at this stage is because bone responds to it by layering more bone tissue, which is a good thing. The final stage is remodeling. This kicks in around the 8th week post-injury and can continue on for years. The bone changes and adapts depending on the stresses that are imposed upon it. The bone that was formed during the previous stages will start to be replaced by the similar bone type as was pre-injury. This can go on for years and resumes as normal bone function. At this stage, the orthopedic consultant may advise that the patient can complete full weight bearing exercises because the bone will have fully merged and joined together. Here are a list of factors that can affect fracture healing time. Type of bone. Bones of the upper limb, arm, wrist, fingers, heal quicker, about 3 to 12 weeks, than those of the lower limb, which takes about 12 to 18 weeks, due to their size. Another factor is blood supply to the bone. Certain bones, such as the scaphoid in the wrist, more specifically the proximal portion of the scaphoid, receive little blood supply. If it receives poor blood supply, then it won't receive the necessary nutrients required for healing, delaying its recovery, and also increasing the risk of osteonecrosis. And lastly, another factor is age. A child has a quicker fracture healing time than an adult. This is because in children they have a more active periosteum than adults. Therefore, they can receive more oxygen and more nutrients to the site of injury. So that's it for today, people. Hope you enjoyed learning a little bit about fracture healing. Subscribe down below to follow for further quick brief answers to questions you may have. Take care, and I'll see you later.